Welcome back. We have Dr. Daniel Deering here, who is going to talk to us about TCAR, and he's with MemorialCare Saddleback Medical Center. Thank you for being with us. And I said the acronym because I just cannot pronounce the rest of it. So please feel free to tell us what we're going to be talking about.
Okay, well, thank you for having me, Lisa. So the acronym is TCAR, and that stands for Transcarotid Artery Revascularization. And this is just a newer procedure that we are offering locally in South Orange County at Saddleback Memorial Medical Center, which is a new tool in our armamentarium to treat carotid artery vascular disease.
Okay, excellent. Now, before we get into the details, tell us a little bit about yourself. I know you have some research background as well, so tell me about you.
Well, so I'm Daniel Deering. I'm a vascular surgeon with OC Surgeons, and our vascular division is based in Laguna Hills. I did my general surgery training at Huntington Memorial Hospital. Mm-hmm. Prior to that, I was in medical school at University of Oklahoma. Okay. And I did a critical care trauma fellowship at Cedars-Sinai Medical Center, and then vascular fellowship at West Virginia University. Okay. And I've been in practice now for, well, since 2012. Okay. I'm married to my beautiful wife, Jennifer, and I have two children, Tommy and Emma, who are 5 and 3 years old.
Oh, wow. I imagine you're very busy, so it must be hard to see them sometimes.
Very busy.
Yes, okay, especially with some of the new things. So what are some of the symptoms of the disease that you're referring to?
Well, the problem with carotid artery disease is quite often it's silent until it causes a major stroke. Okay. It's something like 15 million people affected worldwide by stroke. About a third of those, it ends up in death. Mm-hmm. Another third will have permanent disability. And so carotid disease, or atherosclerosis, builds up in the arteries over a lifetime based on multiple risk factors: high blood pressure, diabetes, high cholesterol, smoking. Mm-hmm. And with this buildup of plaque, as it builds up, it becomes more likely for little pieces of plaque to break loose and go to the brain, causing a stroke.
Oh, wow. Okay.
So unfortunately, only about 20% of patients have symptoms of either mini strokes or TIAs, mm-hmm. or eye strokes called amaurosis fugax prior to having a major stroke. Wow. The rest just simply have that stroke out of nowhere. So mm-hmm. We do have, many of these are detected just based on imaging with an ultrasound or a CAT scan, mm-hmm. or by listening to the neck for a carotid bruit, which is a sound made when there is stenosis in the artery. Okay. But about 20% of those ischemic strokes are mm-hmm. caused by carotid disease. Mm-hmm. So we have different tools to treat that: medical management, traditionally carotid surgery, which has been done since the 1950s and requires a larger incision on the neck. It's a very safe procedure that's been done, again, over 50 years. Okay. And then in the 90s and early 2000s, the process of placing a stent into the artery was developed and researched through a transfemoral approach in the leg. Right. This is a newer procedure, which is a combination of procedures and techniques, which has shown very excellent results in clinical trials. Okay. And now we have over 10,000 patients in a worldwide database showing excellent results, a very low stroke risk, 1.4%. Okay. And we're also able to perform this most of the time through with local anesthetic and a little bit of sedation. Okay, wow. So that decreases the risk of heart attack, stress on the heart and lungs, mm-hmm. quite a bit.
Well, you brought some props here for us, so tell me what they all represent and how you use them.
Okay. So the procedure is performed with a small incision at the base of the neck, and we cut down onto the carotid artery. We then anticoagulate the patient with a blood thinner, and through a needle and wire access, we're able to place this small sheath into the carotid artery.
Okay. Here, let me just hold that up for the cameras to see, so we can at least show. So which part is it? This part that's going in from
It's
the neck?
just the distal 2.5 centimeters
Okay.
that's going into the artery.
Oh, okay, okay.
And-
what is this hooked up to?
So once we've established that, we also place another small sheath into one of the femoral veins.
Oh, okay. Okay, so we've got a couple different processes here. So we have this that's going into the neck part.
And this
right?
is down in the vein.
And then this one, I'll hold it up here for the
Yeah.
camera since they're already on it. And then this one is down in the vein.
Yes.
Okay.
And while
Okay.
we're doing this, the patient is sedated, but actually still following commands. We have
Okay.
them squeeze a little squeezy toy in the opposite hand so we can talk to you and make sure that the person is neurologically intact and doing well throughout the procedure.
All right.
We then
They
connect.
can't feel anything though.
Well, there's local anesthetic, so
Okay.
there's a stick and a burn, and we keep the person very comfortable.
All right.
We then connect the two sheaths with this tubing, which is a flow limiter tubing, and it has a little filter and a flow regulator, and with this, we reverse the flow in the carotid artery from the artery to the vein.
Okay.
So it's based on the pressure gradient, you have established backwards flow that causes any pieces of plaque or clot that form to be swept away from the brain through that tubing and filter
Wow.
back into the venous system of the body. So that's one of the things that makes it very safe.
So it's kind of, is it draining, or how does it actually move the plaque out of there?
Well, this is just to establish that protection. It's called embolic protection,
Okay.
which then allows us to safely cross the lesion with a wire,
Okay.
a small wire, and then where the area of narrowing is, we then place this small nitinol self-expanding stent, which
Okay.
presses against the walls of the.
That is teeny tiny. What is
It's
this made
tiny.
of?
So that's called
That's tiny.
nitinol. It's a nickel titanium alloy
Okay.
developed by the Navy in the 1970s.
Okay.
But it actually has a shape memory based on body temperature, and it's self-expanding. So it's spring-loaded,
Okay.
and it's often constrained into a small tube, advanced, and then unsheathed to
Okay.
deploy that. And it presses the plaque up against the wall of the artery,
Oh, I see.
stabilizes the plaque,
Okay.
and avoids future plaque embolization to the brain.
Does the body ever reject things like this?
It's a very, very rare nickel allergy
Okay.
that has been reported, but extremely
Okay.
rare.
So far it's been pretty successful.
It's quite safe. This has
Okay.
been placed tens of thousands of times in different areas of the body.
Right. And then you have a little vial, what's that used for?
Oh, that's just to hold the stent.
Oh, that's
our-
just this little thing. Okay, good. I thought there was something else. You give him a souvenir.
Yeah, you can keep it.
No, I don't want to do that. All right, so let's talk about what did they used to do versus now, and in terms of recovery. I mean, it must be much easier if you're doing it just under local.
So as a surgeon, this is a great tool. Everybody is not going to be a candidate for this.
Okay.
And it's going to be a discussion between myself or a vascular surgeon like myself, the patient, and looking at all of the risk factors. This is indicated for patients who meet high-risk criteria for surgery.
Okay.
The carotid endarterectomy surgery, again, has been done since the 1950s
Right.
and is very safe. The advantages of this over a carotid surgery is that it can be done under local anesthetic. And so the risk, the stress on the heart is so much less. And also the stroke risk is very low. Compared to transfemoral stenting, the problem with that has always been that it has a higher stroke risk than the carotid surgery.
Okay.
And so it was never completely approved by the Centers for Medicare and Medicaid Services and Society of Vascular Surgeons for treatment of asymptomatic carotid disease. This procedure here has been approved by the FDA, CMS, and Society of Vascular Surgeons for treatment of asymptomatic and symptomatic disease
Right.
because of the very low stroke risk, plus we have an ongoing database for all patients treated with this, and we have over 10,000 patients now showing still a low 1.4% stroke risk worldwide.
That's great.
So this is a great tool for us for people who meet that high-risk criteria for surgery. There are still going to be patients who require the surgery, and maybe even a few that require the transfemoral stenting. But this is an excellent option, very safe, effective, low risk. Plus the risk of nerve injuries, infection, bleeding is also quite low.
Okay, excellent. And then you had mentioned some things that causes the disease, so I would assume preventative would be avoiding some of those things, like avoiding smoking and some other things.
Yes, well, ideally that's the case, that this disease is prevented completely, but it builds up, the plaque builds up over the course of a lifetime. Some of the factors are genetic, some are environmental. Of course, avoiding smoking, getting exercise, healthy lifestyle, and controlling high blood pressure, diabetes, high cholesterol with the help of your primary care physician is the way of primary prevention.
All right, well, thank you so much, and I'm so happy you brought props because I think most people don't ever get to see them unless they've actually been, having the surgery, so I appreciate it. Thank you very much for your time.
You're welcome, thank you.
Okay. And remember that if you would like to know more information about what we've just shared with you, you can go to memorialcare.org/SBTCAR. We'll be right back after this.
Yesterday.